to present today. My name is Dr. Amanda Falk. I am a partner and chief clinical officer at thedorm, which is an IOP and PHP treatment community for young adults with locations in New York City and Washington, D.C. What we know is that data, generally speaking, shows us that between 5 and 7% of the general population has suffered from somatic disorders, yet they often go unrecognized or misdiagnosed. So we are really grateful to bring together Huntsman with us, and specifically to have Dr. Magenta Silberman here to discuss both diagnostic and evaluative approaches to somatic disorders, as well as gold standard treatment interventions. Dr. Silberman is a licensed psychologist with the Young Adult CAT program at Huntsman Mental Health Institute and an adjunct faculty member at the University of Utah. She specializes in trauma-informed care and uses both ACT and DBT in her work. She provides therapy and psychological assessments for young adults and families with experience spanning educational, outpatient, and inpatient settings. She earned her doctorate from the University of Utah and completed her training in Utah and Nebraska. So, without further ado, I'm going to turn this presentation over to Dr. Silberman right now. Enjoy.
Thank you so much, Amanda, and thank you everyone for joining. This is becoming an increasingly more relevant and salient issue with young adults, so I'm excited to dive into this information with you. Let me go ahead and share my screen, and we'll hope that technology cooperates with us today. So far, so good, I think. There we go. How are we looking? Perfect. I just wanted to really briefly introduce the Young Adult CAP program. So that stands for the Young Adult Comprehensive Assessment and Treatment Program. So myself and Dr. Francis are part of the clinical team, in addition to really great social workers that we collaborate with. And we're really a place that people come to when they need answers. We love complicated, in-depth cases to really help young adults and their families understand what's been happening and what's been impacting their lives. I'm really excited to have the chance to share with you two very interesting case studies of individuals that we worked with in our program and how we were able to tease apart this somatic spectrum. So our goals today is, in addition to understanding what this somatic symptom spectrum is, how do we differentiate between each diagnosis? We really want to spend some time and dive through these differentials with real life examples. This is where I really hope to see the chat going off and excited. I want to hear your opinions and questions there. And then I'm going to end with treatment recommendations and how you can support individuals across this somatic spectrum. So first and foremost, we have to be on the same page about what is our somatic symptom spectrum and these related diagnoses. So I'm going to briefly differentiate for you what these presentations look like. So first we have illness anxiety disorder, previously that hypochondriasis. This is probably what we hear most commonly, just colloquially, right? Like, I'm such a hypochondriac. And clinically, we look at this as having a preoccupation with having or acquiring an illness. So there's this significant distress about getting sick. They may or may not experience somatic symptoms, but the distress is of the possibility of acquiring them. Conversely, with somatic symptom disorder, we see this excessive focus on their somatic symptoms, their health. So they typically are experiencing somatic symptoms, but the real hallmark here is the distress associated with those symptoms. They also tend to put a lot of time and energy into their symptoms and health concern. They are the WebMD experts. They are researching, they're going to doctor's office. So there's a lot of time with somatic symptom where they're preoccupied with health. Next, we have factitious disorder, formerly Munchausen syndrome. We're going to focus on factitious disorder imposed on self today. But just so you're aware, there is this component, again, more common in the media. A lot of people are familiar with the Gypsy Rose documentaries. There is a version in which individuals have others in their lives that they will make sick in some capacity, but we're not going to focus on that today. Today, we're going to focus on imposed on self, which is the intentional production of either medical or psychiatric symptoms with the goal and intention, right, of being a patient. That in and of itself is the rewarding aspect, the internal gain of being a patient. And then lastly, perhaps on the more extreme end, I'm going to move our pictures here, forgive me. We have conversion disorder. So this is the presence of neurologic symptoms in the absence of any neurologic disease. So there are common subtypes that we can see. Oftentimes they're experiencing seizures, paralysis, or difficulty with body movements, their sensory organs, even difficulty swallowing. So I want you to differentiate. This isn't just your minor aches and pains. Conversion disorder is the presentation of serious neurologic symptoms with no known neurologic origin. And lastly, when you look at this spectrum with individuals that are presenting to your office or your practice, there's always this question of if there's the possibility of malingering. Are they intentionally producing somatic symptoms, somatic complaints? And is there any external gain that they could obtain by these symptoms? Avoiding work, receiving compensation, etc. We'll talk a lot about how malingering is sort of a complicating factor for many of these diagnoses and how we can go about that in our assessment. So with that knowledge in mind, we're going to dive into our case examples. So first, I want to talk with you about Brian. Really quickly, just developmentally, so you know, pretty typical development, you know, nothing really notable, chatty kid, good temperament, was diagnosed with ADHD at 9 years old, otherwise nothing notable. And he presented to us with significant medical needs. So he was on TPN, which for those of you who are not aware, that's a really significant medical device used to support nutrition, typically reserved for the most, frankly, the most ill patients who are unable to feed themselves orally. You'll often see it associated with cancer patients. So they're receiving their nutrition through a tube in their vein, basically. I'm oversimplifying, but this is a really significant medical device. He also presented with a G and J tube, which are tubes in which he was receiving his nutrition within his intestines. So very significant medical intervention when he presented to us. And his family had the question of, does he need any of this? Like, what is happening to our child? So let me give you some context for Brian and how he ended up with this fairly typical development to presenting to us with really significant concerns. So shortly after his 9th birthday, just shortly after actually his ADHD diagnosis, his sister was diagnosed with type 1 diabetes. And for Brian and his family, that really changed the course of their life. I remember Brian recalled that it was as if his sister was dying, is the words he used to describe the tension and responsiveness that his family had to her needs. And he began to notice the more involved and the more treatment his sister received, the more interested he became in medical equipment. Like he just found himself curious about her insulin pump. And gradually he found himself more interested, more fascinated. He, one Christmas, asked for an IV pole from his family. He asked for a phlebotomy hand, like a realistic, anatomically correct hand to practice phlebotomy when he was about 14. And they began to see this fascination he had with not just medicine, but then being a patient. His parents shared with me a time that he was in the hospital. He ended up being, admitted to the emergency department for this unexplained intense abdominal pain. And they recalled him in the bed, sort of, blanket up, smiling ear to ear, just feeling so excited to be in the hospital, seeing the doctors running around, trying to figure out what was happening to him. As he got older, we began to see more of this patient role. He began to use forearm crutches, reported having rheumatoid arthritis, was sporting the wristbands for rheumatoid arthritis awareness. And slowly his identity really morphed into somebody that was ill. He attended college and he reported intense asthma at the time. And he would be doing these breathing treatments in the dorm like hallway where people could see him and interact with him. So he also began attending nursing school and became more and more proficient in medical lingo information. And then one day he received opioids to address some of his physical complaints of pain. And that's when things started to change for Brian. That's when he went from being a patient to suddenly there were these erratic, reporting episodes of mania, depression, reporting that he was on the autism spectrum. We began to see this shift from physical to psychiatric conditions. And he would report, to the emergency room saying that he was in a manic episode and then would receive either benzodiazepines or other medications to help manage that. And so we began to see this shift from purely a patient role to seeking substances. And then that began a course throughout his 20s of significant residential and transitional living treatment. So for Brian, he went from what was maybe purely a patient role to this really complicated enmeshment with accessing substances, while at the same time still having this factitious urge to be a patient. And I won't go too much into this, but we really just wanted to illustrate that he'd have this urge of he wanted to be in a hospital setting. And at times he would have a genuine medical concern. At one point, he had a benign bone tumor that required medical intervention, but he would take that opportunity and sort of that became his whole identity, right? That was a way for him to access the medical system and then inevitably a way for him to access substances. Right. And for some reason, my slide doesn't want to go. Strange. Hold on, y'all. There we go. So what really helped us diagnostically for Brian is we had this in vivo opportunity where he was here with us and he had been feigning a cough for some time. And we knew that it was feigned because we have Q15s for those of you familiar. So we're checking on patients every 15 minutes. And one of our staff very brilliantly, after a 15-minute check, he was coughing very intensely. The staff just sort of quietly hung back for the remainder of the 15 minutes. No coughing whatsoever during that time. But when it was notable that staff were checking on him, then he started coughing again. So we had some good evidence to suggest that the symptoms were only present when he was under observation. But then it began to morph. He started saying he was having referred pain in his shoulders, trouble breathing, and he went to urgent care. And I don't know how many of y'all go to urgent care when you're sick, but it's not very often that you leave urgent care with scans or any intensive medical workup, right? Usually they're either referring you to primary care or they're, kind of doing a quick checkup. But he actually managed to get a CT scan while in urgent care. And they had an incidental finding where he had a mass in his lung. And it was unknown, right? So their theory in from urgent care was could be nothing, right? It could just be this sort of inflammation due to the cough. It could be like a necrotizing pneumonia that pretty much anyone would have when they're sick, where their lungs are trying to isolate the um, again, this is where I'm not the best MD, forgive me, this is where the PhD is, but but that necrotizing pneumonia is, again, a very common thing when individuals are sick. It's the way your lungs will isolate that illness and keep your lungs healthy. If there's any physicians out there, I know that was not very technically proficient, but bear with me. And then lastly, they wondered if it could be tuberculosis. So for an individual with factitious disorder, right, that's you kind of hit the jackpot with this opportunity. And what was really, really notable for us is he was not distressed, not at all. I don't know about you, but if I was told I had a mass on my lung, I'd be terrified. He was not worried about cancer. He was not distressed. He was actually feeling quite compelled and curious and shared with me, I've never seen inpatient infectious disease. I really want to know what that's like, and was really focused on what a TB procedure could be like. So, what were Brian's final diagnoses on this somatic spectrum? So, we knew he didn't have conversion, right? Because he wasn't having those significant neurologic symptoms. So, our first question was, does he have somatic symptom disorder, right? He's spending a lot of time on his health. And ultimately, that in vivo experience really showed us he is not distressed. He is not experiencing high health anxiety. So for us, we were able to rule out somatic symptom pretty quickly because he wasn't experiencing that associated distress. And at the same time, although he was having a significant amount of time in the medical field with nursing school, he wasn't meticulously researching his conditions, right? Like his day to day was not spent on his health. So then that led us to consider, is he on the factitious disorder spectrum and or malingering? So with factitious disorder, we have this intentional production of symptoms, right? But there's not really this external gain. It's purely for that internal gain of being a patient, which we certainly saw evidence of with Brian. But then the tricky part is there became an external gain once he started to pursue opioids. And it became the question of, does he want to be a patient or is he seeking substances? Ultimately, our answer was both. He would have these desires and urges to be in the hospital, to be a patient. And at the same time, there was this external gain. He was avoiding work, right? He was receiving substances. And so, oftentimes in the factitious arena, you will see this spectrum that they'll inevitably encounter some external gain after being a patient for some time. What was really unique about Brian is he was at the course of his healing journey that he was aware, he had enough insight to know that he had factitious disorder. However, he wasn't present oriented. He would say, yeah, that past stuff was factitious, but this is real. This is really happening. And we were able to do amazing therapeutic work with him to build his insight into how it's presenting in the current time. I'll talk more about that in our treatment. But that's a unique situation. Most individuals are not going to present to you with the knowledge or even acceptance that they have factitious disorder. So I want to switch to a different case study so we can see more of the somatic symptom side of things. So I want you all to meet Howard in the same way that we did. We took a couple of his chief complaints, which was about a page or two, single spaced, of all of the somatic complaints. So we just pulled a few that we thought were pretty notable. And so it ranged from things as, maybe common as hemorrhoids or gastritis, right? But he really wanted to make sure that we knew it was documented and had been assessed. And then we start to see this real preoccupation with his body. So occasionally acute, painful, but momentary sensations of dislocation in my little toes, especially when laying in bed. I mean, that's a person that's thinking a lot about their body. Inability to wink and right eye, right? A lot of us might notice that and be like, well, that's just a weird thing my body does, and we don't experience distress about it. This was something distressing for Howard. He wondered if there was something wrong. um, Loss of muscle with increasingly flabby grandmotherly skin. You can see this, like the way in which he's describing even himself. It sounds distressed, right? Like he's describing it in this very atypical way. Um, Slightly crooked right middle finger, again, something that many individuals might be like, huh, that's weird, and sort of move on. But that was distressing for him. This was really notable and came about even somewhat in his admission with us, feeling, if not reality, that I am not absorbing my nutrients properly. Just take a moment, check in with your body, see if you're absorbing your nutrients, everybody. That's something, again, that I think is really shows just how preoccupied he was with his body, right? That there was so much anxiety of his health that he felt as if he could feel his cells absorbing their nutrients. He also stated that he was iron deficient without anemia that was diagnosed through careful analysis. A theme you'll notice with Howard is lots of documentation. Everything was thoroughly analyzed. That was really important to him that we knew that. He actually came with a flash drive of probably 1,000 files of his medical history and records. And just to be clear too, iron deficiency without anemia it's just not a notable finding. Um, if you have a deficiency but it's not impacting you, that's not a significant contribution to symptoms, just so everyone knows. And then lastly, I have my own suspicion of nystagmus, where the eyes will, it's common for people with albinism, where the eyes will sort of, in his words, flit to and fro. Again, nothing notable on observation for him, but I just want you to see from his eyes to his middle finger to his toes, Howard was worried and thinking about his body all the time. A couple of pieces, again, just for his background when he presented to us. So he had spent the last 4 years prior to his admission with us so preoccupied about his health and body, seeking intervention, seeking assessment. Again, thousand, like probably more than 1,000 data points that he brought to us on admission. And his parents said, it was like he had become a professional patient. So he presented to us with this extensive documentation. And what was so notable is you would think with all of that documentation, Howard would be set, right? His physical ailments have been thoroughly assessed, but from his eyes, they were not. He wanted more and more assessment, more documentation. There were even little minutiae of any physical symptom. He's like, we should look into that. We should assess that. Interestingly, for Howard, which is quite different than Brian, he denied his psychiatric history. So, in addition to his medical documentation, he did have a pretty well documented psychiatric history, and he had fully denied the accuracy of those and felt that any psychiatric diagnosis undermined his somatic or physical complaints. He also utilized quite formal medical language. So rather than saying, he felt faint or he felt dizzy, he would say he was experiencing a presyncopal episode. So he was mindful to use the very specific medical language, and that was consistent throughout his stay. Notable for Howard, he was functioning very well in our program. He previously had shared with providers that he was unable to function and described himself as bedbound. He would be on calls with his providers. Suddenly, he couldn't keep going. He was losing his breath. Never presented like that to us. He was hiking, and I don't know if any of y'all have been to Utah, but the elevation here is no joke, especially on a hike. And he was pretty minimally winded. So he was able to participate well until we named that and identified that, and then his symptoms suddenly escalated. He was nauseous, dizzy, couldn't leave his bed. And his goal was that he wanted to move home and have his parents take care of him. He had documentation from his providers that that was the only hope for recovery for him. And even with the best optimal caregiving, his best hope was about a 50% recovery. So, what are Howard's final diagnoses? So our first inclination in this case is we wondered about factitious disorder, especially whenever you see professional patients. That has you wondering, is this person seeking to be a patient? And what's tricky with Howard, namely, is that he had a number of documented physical conditions that we couldn't necessarily disprove. So with Brian, we were able to assess and determine that he did not have the gastric complaints and diagnoses that he reported. And by the end of his admission with us, he had all of his devices removed. With Howard, there was a lot more nuance that we couldn't explicitly prove or disprove, whether or not he had those symptoms or if they were fabricated. So ultimately for him, factitious is sort of still a rule out realistically for him. But we found that it wasn't so much that he was assuming a patient role as it was that he was so preoccupied with his health. So he would be spending any free time, like I said, researching. He was on forums and subreddits and what about this unique thing or this niche program in New York City or wherever. So he was spending a significant, I can't tell you, like I can't undersell how much time he was spending looking at his somatic concerns. And we did find that he had a high level of anxiety associated with that. He would often tell us he was worried that he would die if his illnesses were missed, that we were potentially ruining his life because it would lead to his inevitable death. So he had a high degree of health anxiety that we certainly felt met criteria for somatic symptom. At the same time, again, this tricky malingering component, he had really clear external gain. He wanted to not work and he wanted to be cared for, and he felt that was his only hope. And what was interesting is when we explored with him, what would rest look like? Like, what is a meaningful rest for him? It still included researching and doing medical workups. And again, I don't know about y'all, but going to and from doctor's appointments and having all these procedures that's pretty effortful. And so his health preoccupation was still so significant. At the same time, he really was quite work avoidant. I did also conduct some explicit malingering assessment for both Brian and Howard, and they were elevated. So we again went with somatic symptom in this case, plus malingering. Um, for him, factitious disorder is one that we lean away because of the associated distress, but it's possible that there's a greater degree of deceit for him. He was a really complicated case. I could spend the whole hour just talking about Howard, but alas, we don't have the time. So I do want to end on Dr. Francis and I really wanted you to have a clear example of, okay, how do I suss these differentials out? And we wanted it to be really easy for you. So please, we will share our slides, but feel free to screenshot this. We think this is a really helpful way to conceptualize the differences between these diagnoses. So on the top here, we have the different somatic symptom and related disorders. And then these are the diagnostic areas that we're considering. So what's the level of distress, right? With somatic symptom, it's going to be really high. With conversion disorder, it's actually typically absent. There's this phenomena that people with conversion will be like, yeah, I lose sensation in my legs sometimes. It just happens. There's not this same associated distress like there is with somatic symptom or illness anxiety disorder. Insight is really important to assess. So for factitious disorder and malingering, they're going to have insight, but they're going to be deceptive about it. Versus conversion, they don't have insight. They think this is a genuine condition. Similarly, somatic symptom and illness anxiety, they can have some degree of insight, like maybe I'm, worrying too much about this, but they also believe that their symptoms are genuine medical concern, and in some cases they are. Um, so they do experience true somatic symptoms. Individuals with chronic disease are also more at risk for somatic symptom because they experience a greater degree of distress of their symptoms. Whereas again, in factitious and malingering, they're not having subjective experiences of somatic symptoms. When it comes to those objective observations, are we as the clinician going to see symptoms, or if they go to a medical office, are they going to find anything? With factitious, they're going to have a lot of data for you. It's typically like copious amounts, but it's unreliable, and they're usually these sort of ambiguous, sort of rule out diagnoses, wherein we assess for all these things and they weren't present. So maybe it could be this. It'll be these more kind of vague, unclear diagnoses. And typically across the board, we don't see a lot of objective observation except in somatic symptom, where again, they may have a chronic illness that's bringing about a lot of distress. They may have genuine pain or nausea, right? That can be assessed. But oftentimes the distress is disproportionate to those symptoms. You'll also want to look at external and internal gain, especially with malingering, right? You need to see, is there anything they can gain from this? And then lastly, we always like to look at their transparency. How much are they willing to share and work with you? So typically with illness, anxiety disorder, and somatic symptom, they're like, yes, please, here's all my data, please help me. And they feel really soothed and responsive to you as your team that's there to help them. With factitious disorder, they're more likely to gatekeep information and say, like, no, I won't give you a release to talk to this hospital. Again, conversion disorder, complete transparency typically too. They're like, help me understand why I'm having these seizures. And what I find with malingering, this isn't always the case, but I find that they're more likely to be transparent about the thing they're malingering, right? So they will tell you all about their memory problems or their somatic complaints. But if you ask them, tell me about your mood history, they're like, that's not relevant. Why do we need to talk about that? So they're more likely to be transparent about this sort of specific symptom set. All right. And then I want to end with our treatment recommendations. Now we're all experts in that diagnostic differential. So what do we do when they present to our practice and our programs? There's a few things. The first, no surprise, right? Psychotherapy. The predominant research is on CBT, which is really true of most psychotherapy interventions, motivational interviewing. And then there's emerging research on the effectiveness of ACT and DBT, particularly for them to be able to learn distress tolerance skills, how to manage the anxiety that they feel, and also being able to balance, with ACT, am I moving toward or away from the life I want to live, by how I'm responding and approaching my somatic symptoms. Relaxation techniques are going to be critical. Inherently, that somatic distress, relaxation techniques are going to help reduce that, but it's also helping with their coping capacity. I wanted to identify something unique about conversion and factitious disorder is it's actually an evidence-based strategy to give them an out or a cure. This is going to sound so counterintuitive as a clinician, but giving them an out is a way to sort of explain the symptoms where they don't have to experience so much shame and guilt, particularly for factitious, where they have the knowledge that they're producing symptoms. They know this, but it's such internal conflict because of the the patient role gives them so much that to let go of that is really challenging and really shameful. So physicians can give them an out in a way to say, for example, individuals who experience chronic rheumatoid arthritis after periods of time of relaxation, they tend to have spontaneous remission. And then suddenly you'll see these individuals stop presenting with those symptoms. Similarly, for conversion disorder, presenting them with the fact of, you don't have any neurologic condition, you're faking it, that's not going to give them any result. That's not going to change their presentation at all. If you're able to offer a cure for them, like again, many individuals will have the spontaneous remission, or if you do this physical therapy exercise, that will bring feeling back to your legs. Seems really counterintuitive and in its own right might feel a little dishonest, but it's been shown in many ways to be more effective for folks than this direct confrontation. That said, sometimes you have to have a direct confrontation, and the best way to do that is in the most non-judgmental approach that you can. So something to the effect of, we've done a really thorough medical workup. They've all come back typical. And I know that you're still experiencing a great degree of pain and nausea and symptoms. I think it's time that we look if there could be a psychiatric contribution to what's going on. So direct, non-judgmental, that's going to be more effective for like somatic symptom presentation, illness, anxiety. Sometimes for factitious disorder, if you're encountering them in the medical system, like sometimes you just have to be direct, right? I can see that this data has been tampered with. I can see this. And again, we don't need to be judgmental, but sometimes you just have to name that that's what's happening. It may not always result in change for them, but you are still helping them in the fact that you're building their medical record to show the concern. That was actually really helpful for us with Brian. Those early providers that could see the factitious and named it really helped us later on in his life. Again, a predominant focus of treatment is going to be improving coping skills and helping to reduce their health anxiety. You really need to have interdisciplinary collaboration. This is a time where we can't just be in psychology by ourselves. We need to really work with primary care, psychiatry, if that's relevant for your patient. For factitious disorder, you need to have one internist that's coordinating and communicating with everyone. Again, individuals in the factitious spectrum are often going to silo their providers and not allow them to communicate. That's where you have to be really upfront and say, we're not going to do that. The most important thing is that we're all part of your team. And ideally within the same hospital system with the same shared medical documentation programming. So there's no secrets. And a piece that I think individuals can really be lacking oftentimes is this meaningful life outside of being a patient. So we can focus as much as we want about coping skills and reducing anxiety, but if individuals don't feel that they have a meaningful, well-connected life to engage with, they're very likely to fall back into those same habits, behaviors. So a really important part of treatment is helping them uncover, what are you passionate about? What do you care about in this life? And how can we bring more of that into your life? And also helping them with insight to see how their preoccupation with illness may be getting in the way of accessing that meaningful life. This was especially helpful with Brian and his course of treatment, and similarly with Howard. Do you want to work? Do you want to have a family? And for individuals who have somatic symptom, again, accepting like you're going to have physical symptoms and you want to hike and see the world. How can we make both of that happen? So I really, if that's one piece I really want people to take away is therapy is a great opportunity to connect individuals to their purpose and meaning. And it's really important, especially for these folks. And lastly, it's really helpful to focus more on the coping and recovery side rather than etiology. Folks with somatic symptom want you to get caught up in etiology with them. They want to know the origin, and so they want to kind of suck you into that too. And so the more that you can focus on, I hear you, you've had all these ambiguous tests with unclear findings or negative findings. But how do we just focus on helping you recover right now? And I did want to also leave you, I think factitious disorder is one that there's not a lot of clear resources out there. So these were a couple that we found really helpful in our work, both diagnostically and treatment. On some of our cases, we even consulted with Dr. Feldman, the author of these books. He's considered, one of the leading experts in the field. But these are really great resources for you. And with that, I'd love to turn it over to our discussion.
Thank you so much, Dr. Silberman. That was wonderful. We have a lot of activity, both in the Q&A and in the chat. So I'm going to get to it so that hopefully we can get to a bunch before the end of the hour.
Great.
A question that came in pretty early on in the chat is asking if you can explain the difference between contamination, OCD, and illness anxiety disorder.
Ooh, yeah, good question. So contamination OCD is typically, I mean, there's going to be some degree of overlap, right? Like, let's just acknowledge that. But typically with contamination, they're more focused on these external, right? Like germs and like these products are going to contaminate me versus that preoccupation. It's normally internal, like I'm going to get sick. These are the people, that are like, oh my gosh, I was in the market, I'm going to get monkeypox, right? Like or I had a cough. Does that mean that I have COVID? So they're going to be preoccupied with the physical symptoms and how that relates to illness versus germs. Great
Wonderful.
question.
Yeah. Another question came in asking if I'm wondering, in your experience, are you seeing more individuals come in with these disorders? And if so, like, why? Why do you think they're on the rise?
Hmm. Yeah, I would say more often than not, we're seeing individuals with somatic complaints, right? Whether they're rising to the occasion of a diagnosis, but certainly an increase with that somatic symptom presentation. Dr. Francis and I spoke quite a bit, something that we didn't have the nuance to get into today. Each of these individuals, Brian and Howard, also had comorbid personality disorder diagnoses.
Yep.
And so we were wondering, could we even talk about that correlation, right? So from my perspective, I see a couple of explanations. This is just anecdotal, no research, everyone. You're just getting Magenta Silberman's opinion today. But I think there's an increase for a couple of reasons. One is for a lot of individuals, it is safer, easier, more accepted to talk about physical symptoms than it is emotional.
Mhm.
And at the core, it's a physical representation of our emotional experience. I find, at least with the families that I work with, parents are generally more receptive when their child says, like, my stomach hurts, I'm in pain, I'm uncomfortable, versus when they say, I'm sad, right? Sometimes parents don't know what to do with that.
Mhm.
But they know they can make like chicken soup and help you feel better when you're not feeling well. Um, that's a big piece that I've seen.
We did have somebody in the chat state that the behaviors described also seem to parallel BPD, which has been more clearly connected to childhood trauma. So, yes. A question came in, and hold on, let me get back to it. I'm like, there's so many. I'm scrolling
No
um,
problem.
back and forth between these um, around. Individuals, or if you have any experience in sort of where you would classify um, non-epileptic seizures, sort of these psychogenic seizures. We're certainly seeing more of that as well. Can you speak to that at
Mhm.
all?
Yeah, typically that will be in more of the conversion spectrum, particularly right where there's no neurologic findings. I have seen an increase. Again, it's tricky differential. I'm thinking of a patient that I worked with who, again, when they were distressed, would sort of feign seizures. And a lot of, I mean, she fooled a lot of providers who thought that she was having genuine seizures in the moment. But for her, it was a really effective avoidance strategy to get out of whatever distressing situation she was in. Um, and I think that so realistically be part of that conversion spectrum, but I would just be curious about the potential feigned component that could be there. And I would be curious, is there any external motivation to engage in that behavior?
Mhm. Yeah. Um, Another interesting question too, and this again looks more at the group in terms of, or peer support in terms of treatment. What role do you think peer support can make in the lives or the treatment for these individuals? What recommendations would you offer in terms of either peer supported groups, or I would add to that, uh, therapeutic groups that are facilitated by a clinician?
Mhm. Yeah, I see that twofold. So focusing on therapeutic groups, I see a great opportunity for shared healing, and I see a great opportunity for shared catastrophizing.
Yep.
So there's a real chance that it can turn into this catastrophizing of like, I'm having unexplained itching. Oh my gosh, so am I. I can't focus my eyes. Neither can I, right? Like this contagious effect. So I would
Mhm.
be really mindful as a clinician how the the somatic talk goes.
Right.
And the focus and the goal there, because at the same time I think it's so validating to have someone say, that's so challenging. Like, wow, how hard that must be for you. Do you want to like go for a walk and distract yourself? Right. Like, I
Right.
love peer support, but I think in a therapeutic context, we just have to be really thoughtful that we can set expectations and navigate potential catastrophizing that can happen. We've
Right.
definitely seen that in our own program, and we've had to address that. It's really hard to not have some contamination there.
Yeah.
Um,
Like
but at the
sharing
same
of medical records, like, oh, let's compare, look at my notes
yes.
versus your notes.
Yes, exactly. So if we can like I'm a big fan of let's not focus on the symptoms, but let's talk about feeling. Let's
Yeah.
talk about how we want to approach that,
Mhm.
and build community because I do think community is really helpful for people.
Yeah. You had mentioned a bit of a family component here, and how
Mhm.
a lot of times, even for parents, it's much easier to handle when your child comes to you and says, my knee hurts or my tummy hurts, then I'm feeling sad or I'm feeling upset. How
Mhm.
do you and then you get these families, right? Because you're treating the system often in treatment. How do you work with a family when they are also resistant to accepting a conversion or factitious disorder, and maybe are just as attached to um, the medical or the perceived medical issues going on as the client themselves is?
Mhm. Great question. And I think as a clinician, that's extremely difficult, right? So I would typically, my recommendation is always meet them where they're at and begin to push as much as you can. So if there is this shared understanding of like, yep, my child is very sick, they're debilitated, then let's talk about this shared area. You're naming that you think the cost, it's becoming really debilitating on finances. Let's talk about a more effective way that maybe we can access treatment, right? Or maybe, like they're so sick, but they really want to work and I don't know what to do. Okay, well, that's a great in with the family of let's talk about how to support vocationally, right? And then we can begin to push. Wow, they were so successful here. I wonder if we could try this. I wonder if maybe it's not as significant as we thought. I also think that to the degree that your young adult has insight and accountability, the more that it can come from them, the better. I think specifically about Brian, and who again, and by the time I met with him, he had acknowledged to some extent the factitious. But even in his current, I mean, TPN is not cheap, y'all. GJ tubes are not cheap. And it was really important that even though he was so, him and his family thought that was real.
Mhm.
And it very well might have been a symptom at one point. Um, So we actually went through family exercises of having accountability of the financial cost and burden in a way that didn't shame Brian, but was like, I want to do this differently next time. And we came up with a plan of maybe if I'm feeling an urgency to get a procedure done, I should call you first.
Mm,
Uh, and bringing in the family as part of treatment. And so then they're bought into the process too.
yeah. Was there screening for trauma, including childhood trauma, premature both birth and attachment trauma in these cases? These people sound like they have highly anxious attachment types in their attention-seeking behaviors.
Yeah, we did screen for trauma, for Brian and Howard, and that was not prevalent for either of them. That said, your question does remind me of another patient I worked with who had a comorbid borderline personality organization, who did have some more extensive trauma. Um, so I think that it certainly can come up, and we know that trauma has a very physiological component to it as well, as far as how it presents in our day-to-day lives. For Brian and Howard, it was not pertinent or relevant, but I have seen cases where trauma responses can definitely amplify that somatic symptom or preoccupation with health. Good
Mhm.
question, though. We always want to screen for that.
Yeah. There's another question coming in again around just comorbidity with BPD. I think this is high on people's mind.
Yeah.
Um, how are individuals with BPD's tendency to exaggerate slash amplify pain incorporated into this somatic spectrum?
Yeah, I see it in a few ways. One is their lability also has a somatic component. So I'll use this particular patient I was referencing. So she had this very cyclic, it was itching, burning, pain. She would frequently complain of like a vaginismus, if you're familiar with that. So pain in her vagina, which she would then use as a push-pull technique of like, I can't tell you that because this is personal, but I can tell you, but you
Mhm.
can't tell anybody else. So it had this very push-pull component, but and then again, it would just cycle through repeatedly. Um, and I found that the more of that labile mood, her somatic symptoms really followed that. Again, it became sort of a strategy in and of itself to have that interpersonal difficulties and sort of push or pull people. There was even that degree of triangulation, right? Of she told Dr. Francis about her experience, but was like, you can't tell Magenta. That's personal. So I do look at how they're expressing the symptoms, right? And how that could show up interpersonally. I think it can also, in some ways, correlate with some of that riskier behavior. They might engage in substance use to try to numb somatic symptoms, um, right? But I see how, again, we have intense mood, we have intense emotional experience. It makes sense to me that it would be expressed in intense ways, including physically.
Right.
Again, that should be its own talk. Maybe next
I
time,
know.
Amanda.
I know. There was also, and we don't have time to get to it right now because we have 2.5 minutes left, and I'm mindful of giving people a break before we fully end. But some questions too with comorbidity around ASD as well, which also I think makes complicates just like the treatment and the intervention portion of things as well. So
Sure. Yeah.
um, thank you so much, Dr. Silberman. Thank you to
You.
everybody who came today. The chat and the Q&A was wonderful. Clearly, we need to do a follow-up presentation on this because there were so many wonderful questions that we are just not going to be able to get to. Please remember you will be getting an email with instructions around how to get the CEs. We will have slides available to everybody as well, and we will definitely plan something in the future because this is obviously a topic that's an area of interest for lots of people.
Thank you so much. And thank you, everyone. This was amazing.
Wonderful. Have a great afternoon, everyone. Take care.
Thank you.